we have some really exciting speakers. And also it's the first day of June, so want to welcome everyone. And we have some interesting cases to show. So we're going to start off with showing some cases, and then we've got some excellent panelists and a great talk by Liz Walker about women in spine. So we're going to kick it off with some cases. Dr. Pratt is going to show a very difficult correction that we did a couple weeks ago. Nathan.
Thanks, Dr. Skoyan. Hi, good morning, everybody. Hi, Nathan Pratt. I'm one of the fellows here at Swedish, trained neurosurgery at the University of Maryland. So our case today, 65-year-old patient with adolescent idiopathic scoliosis, treated with a brace for 1.5 years when he was 16 years old. Now presenting with severe low back pain, right greater than left lower extremity pain, as well as mild hip esthesia. He's undergone several years of conservative therapy, many years actually, of conservative therapy. Obviously, this never had any other operation prior to him presenting to us, just the brace. But now he's having significant impairment. He's actually a very physically active person, still gets out, golfs, things like that, but this has severely limited his ability to do any of the sort of activities that he likes to do. His only real medical issue is he does have some stage 3 chronic kidney disease, otherwise just kind of standard things, and then the rest of his history sort of not very exciting. He has some weakness in his distal lower extremities bilaterally, but and hyporeflexia in the lower extremities, but otherwise kind of an unexciting physical examination. He has a slightly forward flexed posture and a neutral coronal plane. Here are his standing scoliosis x-rays. Is a fairly high pelvic incidence of 72.3 degrees. His lumbar lordosis is about 47 degrees. Pelvic tilt, he's significantly retroverting his pelvis, almost 30 degrees. His SBA is positive 5 centimeters. He has a dextroconcave curve from L4 to T12, measures about 53 degrees, and a levoconcave curve from T4 to T11 that measures about 66.5 degrees. And I show you a couple of slices on the CT myelogram to show dye blockage at L2, 3, 3, 4, and 4, 5. As well as some blockage at 5-1 as well. So in addition to the scoliosis, he also has significant foraminal and central canal stenosis. So again, having failed all the conservative management options that we have for the patient, we planned for, try to limit our surgical intervention to a T9 to pelvic fusion. He wanted the smallest possible surgery to get him back and active. And we felt that there's really no way to decompress that, just that lumbar area without going up to the thoracic spine, trying to at least partially correct his coronal curve as well. He understood that, one of two things would happen. Either the upper instrumented vertebra would be higher than what we had thought, or that he would need additional surgery, or perhaps even both. But he's fine with that. We don't have a standing scoli x-ray afterward. Unfortunately, as we're operating, we figured out that his kyphosis, his gibbus, would have been like at the T9 level. And so we would have been fusing him almost into a kyphotic posture. So we had to go up to T6. But we got a pretty good realignment here, both in the sagittal and the coronal plane. Again, he's laying down for this. This is a scout film from a CT scan, but his lumbar lordosis is certainly greater than 60, 65 degrees at this point. When we get a standing film, we'll know for sure. And so he remains coronally balanced, which is a big issue with anytime you have somebody with some coronal deformity that is balanced, you don't want to throw them off. So obviously that was a good thing there. Required extension. He was in the ICU only for a couple nights. This was a patient who, unlike a lot of deformity patients, did not require a lot of pain control, was tolerated the surgery very well. and he felt like he had improvement in that bilateral lowers. He was ambulating well, but still needed to go to rehab for a while. And then here are our post-operative films. I think one of the things Dr. Chapman wanted me to mention, not specific to this case, but to all spine surgery, one of the reasons that it's unpopular within orthopedics at least is that the patients are in the house for quite a while a lot of the times. They require a lot of pain management, a lot of hand holding, because they feel pretty miserable after this size operation. And so I think that within ortho, that's kind of problematic. I think for neurosurgery, it's a little bit different. We have kind of a different mentality. There's not outpatient options in neurosurgery. So anyway, and obviously the scale of this operation, this is a very physically taxing operation for the patient as well as for the surgeon. So it's a lot of work to put this together, obviously, but a nice outcome here for this patient.
So Nathan, I have a couple questions. Yep. So first of all, in terms of working this patient up, what do you think was the thing that made the patient decide to have surgery? Because this is not a minor surgery.
Right. So for this patient in particular, he had been pretty well compensated for many years in terms of his spinal deformity. So the change for him was in physical limitation. He couldn't walk more than, a block or two. He had been wanting to be physically active he wants to golf again. I don't know how much he's going to be able to do that, because he's not going to really be able to turn, but he couldn't do it before the surgery anyway. So that was why we wanted to stop lower. But if we'd done that, he would have been back in a month, just.
And then another question, and this is directed towards you.
And weakness, obviously, in his feet.
Weakness as well. This is probably like a 10 or 11 hour case. So physically, this is extremely demanding. Do you want to talk about how long this case took and what your thoughts are on doing a case like this? Like, do you do 2 or 3 of these a day?
Thank you, Rod, and thank you for the nice presentation, Nathan. I want to, again, really express my appreciation to Dr. Liz Walker, a graduate from USC, on taking on the thorny subject of women and spine, and Dr. Pooja Prabhakar is online. She's a UW resident. And maybe I'll deflect the question to Dr. Prabhakar. Pooja, briefly outline, if you will, what the spine exposure to orthopedic residences in a major program like University of Washington. And thanks for being here, Pooja.
Yeah, thank you all for having me. I'm a third-year resident at UW in orthopedics. So our spine exposure generally starts second year. We have a 6-week block at Harborview, followed by another 6 to 7 week block as a fourth year at Harborview. In between, we have another 6-week block at Seattle Children's Hospital with pediatric spine. And then kind of throughout, from first through fifth year, we do work at UW Northwest with our spine surgeons there, kind of interspersed between.
So this is a pretty nice spread. Where does spine in general rank in orthopedics in terms of popularity? I know that sports medicine, hand surgery, and arthroplasty are kind of the top 3, and all have the same theme, kind of their relatively quick surgeries. Honestly, where does spine rank?
I think, at least nowadays, it's we have probably in our class of 8, there's usually at least one resident that goes into spine each year. So maybe not like at the end, but probably in the middle towards latter half of all the specialties.
And as a more junior resident, when a big case like this comes in, what would the role of a junior resident be? Would you kind of be actively involved in assessment, decision-making, planning, and surgery, or would there be more a secondary assist role or tertiary assist role?
Yeah, I'd say it's mostly a secondary assist role. Usually, at least at Harborview, we're kind of with the fellow doing the surgery. Sometimes the attending kind of bounces between rooms. And then we do have our preoperative conference that we do present at. So there's a bit of planning involved with the fellow as well.
Yeah, so thanks for providing that perspective. So to answer Dr. Screen's question, the main problems of this patient as identified by Dr. Pratt were he had 2 very significant areas of stenosis and 2 areas of significant foraminal stenosis. And obviously, He comes from out of state, from one of the sunnier southern states. He was highly interested in an MIS surgeon. He'd seen several surgeons that who told him that they could do that. And I felt that that was a really bad idea, specifically on the CT myelogram, but this certainly was discussed. So to Dr. Pravakar, very honest response, just regardless of the topic today, amongst residents, when you see that there's a 10-hour case rolling your way, is that something that is met with enthusiasm and yay, or is it like, oh my God, there's a slug coming?
I mean, I think it depends, but yeah, sometimes I think comparing it to our other cases, which are usually a little bit quicker than that, it can be a little daunting. But I mean, I think some of us are used to longer trauma cases as well, but definitely the spine cases, I think, are the longest.
Yeah. Returning it back to, thank you for your answers to Dr. Skurian. Do you think that I could have done something less invasive, like just a limited decompression from the spinal spacer and not make this a 10-hour slug and fulfill a hospital administrator's dream of getting 3 to 5 cases done a day rather than one big one?
No.
Rod,
Sorry, Jens. You cut
could
out
I have
there.
done a more limited case? Could I have done a more
No, I
limited
mean-
case there, do you think?
I think honestly, I think you guys, I don't think you could have done anything smaller. I was surprised that you were going to go T9. I would have probably gone a T4, but I think T6 is fine. I think on a double major curve in an adult like that, I think if you're going to do anything, I think my philosophy is either you fix it or don't do anything at all. I don't think you can do an MIS case on it. That looked like a very rigid deformity. And I think you got a beautiful correction. The hard thing always, Jens, is, that patient didn't look like they had any, their shoulders looked balanced. Coronally, they seemed to be balanced. It seemed like it was more of a kyphoscoliosis. Was I correct on that?
That is correct. Yes, he'd done extensive therapy. This patient had some means, and so he'd really done anything non-surgically.
My question to you on that case is, you did so many, you did some nice intradiscal osteotomies. It's always difficult. How do you decide which side do you do it on, or did you do bilateral on each level?
We did a full bilateral release on every level, and basically just built up the concave sides and translated the 3-4 lateral ascesis. So that was the technically hardest part.
Yeah, that was a beautiful correction. So great job.
Thank
Okay,
you.
we have our next case. Dr. Titern is going to present another case.
Good morning, everyone. I'm Zach. I'm a neurosurgery spine fellow here at Swedish. I have a quick case for you. That was done a couple months ago here. So this is a 52-year-old woman. She's known to our clinic. She's calling chronically for continued back pain in the setting of a known T8 fracture. They have a significant medical history, significant for diabetes, COPD, pituitary adenoma, resulting in supraphysiologic steroid use for adrenal insufficiency, 2-pack per day of smoking history, and just dozens and dozens of monthly phone calls about refills for pain medications. So her complaints are constant bilateral lower extremity pain, progressive myelopathy, problems with her balance, progressive deterioration of her lower extremity function, now confined to a wheelchair. She had a couple months prior to seeing us in clinic, history of some L4 to S1 facet blocks, which didn't do anything. So her exam is on the right. You can see she's markedly diminished in her lower extremities. She's frankly myelopathic on exam. So pre-op X-ray imaging, you can see you'll see in the subsequent scans that she has a vertebral plana at T8, as well as a 40% compression fracture at T6, and a kyphotic deformity at the level of the pathology. This is pre-op imaging showing CT, MRI, sagittal. She's moving a lot, not the greatest study, but you can see the marked wedge deformity. In addition, the area where her spinal cord looks most stenotic at the level of the deformity. It kind of looks on the T2 parasagittals that's mainly just fat compression, most likely due to the chronic steroid use over the years. So she was taken to the OR. She was taken for a T4 to T11 posterior instrumented fusion, Lammy's from T7 to T9 where she was tightest, and a vertebrectomy at T8. These are some intraoperative photos. Postoperative imaging, good decompression, good deformity correction, still a little tip forwards, T4 to T11 hardware. The screws all looked good on axial CT scans. 2-month postoperative, she's still complaining of progressively worsening back pain and complaining that she feels like she's tipping forward a little bit. These are her scans that show she's wedged a bit forward more at the distal instrumented segment. So she was taken back for a T12 kyphoplasty. This is about 3 months postoperatively now, which did ameliorate her pain significantly. So this is her postoperative imaging. Her initial pre-op x-ray is on the right, far right. She remains wheelchair bound as of last exam last week, but her pain has improved and she's not displeased with the surgical results.
So Jens, I wanted to show you guys this because I think, you couldn't really see it on that sagittal MRI, but she had cord signal change there. And, this is a case of myself and, this is, I think we probably should have gone longer. But that piece of bone there, you can't really see it there. She actually neurologically got better. And then now she's got this horrific kyphosis at the upper level. So what do you think I should do?
Personally, yes, this is a super compelling and difficult case. The technical execution is great, but obviously this case illustrates the terrible problems of these polymorbid patients. And this is where I want to, again, good morning, Dr. Coring, talk a little bit about how difficult these patients usually are or can be in larger spine centers. It doesn't need to be anywhere, but there's clearly a high likelihood of problem patients. And they need to be very thoroughly worked up. It's a multidisciplinary problem. Let me ask Dr. Walker. Liz, you were looking back at your successful tenure as director of AO Spine North America, and without taking anything away from your talk later, what kind of are the characteristics of the typical AO spine surgeons that you saw just in general when you see these kind of real problem cases, which make up a lot of the discussion points that we always chew over?
Sorry, I was on mute. Thank you for the question. I think the spine surgeons that I've worked with over the years are definitely very type A, want to high energy, want to certainly be the best of the best. And a few minutes ago, when you were asking Pooja a question, it reminded me of her resident experience of, kind of long spine cases. There was a quote that I ran across in my research from Bain 2008. It was talking about neurosurgery in general, the profession, and it says it appeals to individuals who persevere long years of difficult training, treat high-risk surgical procedures, accept profound responsibility, and face extraordinary levels of liability. It will never be the haven for the timid. And I think that really kind of sums up the people that I've come across over the years and the things that you all do on a daily basis.
Yeah, thank you. Dr. Coring. Dr. Coring joined us. She's a very successful foot and ankle surgeon. She's a younger surgeon. She's in Spokane, Washington. She's in private practice. Dr. Coring, you're in a multi-specialty group. What do you as general orthopedic surgeons or as other subspecialty trained orthopedic surgeons do regarding spine coverage? Is this something that you have to do? Let's say this patient comes in on your call night and you have you get called, this patient has a new T12 burst fracture below a nicely placed hardware, and she's a train wreck. How does that get solved in private practice?
I'm sorry, was this directed to me, Jens?
Sorry, yeah, this was at you. So in a multi-specialty
Sorry, I had
spine cover.
Yeah.
In a multi-specialty group, how is spine coverage handled in orthopedics? This patient, assume, comes in with a T12 burst fracture in the middle of the night, and you're on call, and you saw the laundry list of medical problems and idiosyncrasies, shall we say, medication use, opiate use. How does that get handled in orthopedics in a multi-specialty?
Yeah, so actually where I'm at, we don't cover spine call. Neurosurgery exclusively covers that for the hospital contracts that I'm at for call. And so I guess fortunately don't have to run into this situation in kind of my current practice setting. So hard to kind of give you my perspective on that.
I was asking because medical legally, this is a very big deal. I don't do
Yeah.
a lot of medical legal work, but cross coverage in a multi-specialty orthopedic groups is a real problem.
Yeah.
And it's, again, very unpopular in orthopedic groups to be called about a spine case like this. And so there are frequent issues where there may not be the same response that a pure spine community would like to see. And there can be very contentious things coming around that. So do you have a spine surgeon in your group? Actually, or is there no spine surgeon in your group?
Yeah, we've got 2 spine surgeons, another one coming in the fall. And so they will cover call over at our level 2 trauma hospital. But these types of, we'll get like practice calls on patients concerned about like, wound things or et cetera. When I do get any of those patient calls, I always contact the surgeon because it's kind of no longer part of my scope of practice. And obviously I know what to do for a lot of this stuff, but I always want to make sure they're aware with draining wounds, et cetera. So yes, but, kind of separate from that, they cover all the, kind of just trauma cases as they wish to. And one doesn't even take trauma call anymore. So.
Yeah, so coverage can be an issue, and there's always a complex arrangement because, again, it's like an island in itself, spine surgery.
Oh, yeah.
Right. So Rod, to answer your question, I'm afraid that over short or long, this patient's overall proclivity to imbalance, metabolic derangement, multiple physiologic problems will necessitate that you go to the pelvis. That's my unpopular thoughts.
What do you think I should do with that fractured level? Do you think I should take out that screw and do a vertebrectomy, or just do an IDO at the level below?
I've usually done IDO, so intradiscal osteotomies above and below, especially since there's cement in there. But as a backup plan, I would have a VSO, so a vertebral subtraction osteotomy option. Thanks.
Great. Thanks, Zach.
Who's next?
Rod, can we switch to program at 7 o'clock, so one more case, and then switch? Or how many cases do you have left?
We got a couple more cases, and then we'll switch to Dr. Walker here in a second.
All right.
Rod, program-wise, we're going to have Pooja start first
Okay.
with just a quick overview of women in orthopedics. She has a very good perspective on that, and she has a 5-minute abstract, and then switch to Dr. Walker.
Okay,
Thanks.
sounds good. Okay, Jared.
So close with the name. Okay, so I'm Jared Cook with an E, and trained in southern New Mexico. So go through this kind of quickly. So we have a 78-year-old female comes in with balance difficulty and 5 recent falls, ambulates strictly with a cane, right foot numbness, leg pain. So the history is T11 to S1 fusion. In 2014, there was probably a laminectomy before that. It's questionable based on history. T4 to S1, revision, extension of fusion 2016, and ACDF in 2021. We'll kind of go through those real quick. And so her exam shows a little bit of deficit in the right lower extremity. So initially she was seen in outside hospital. She had a disc herniation per report, treated with probable laminectomy, another disc herniation and pain, and treated with a T11 S1 fusion. She was fused very, very straight. And then after that point, presents to us, so the history gets a little bit better. So she comes in with a thoracic myopathy, paraplegia, leg weakness, spinal stenosis. You can see that at the 8-9 level. So treated with a T4 to T12 arthrodesis, partial corpectomy of T9, and a T8 to 10 laminectomy with a revision of T11. So here is the construct at that point. So then she basically disappears despite our best efforts, and shows up again in 2021, comes in right foot drop, paresthesias, difficulty walking. Posture is forward bent, she's falling, and says that after the most recent fall, she developed, quote, worsening neuropathy in the hands and legs. And so here's what her cervical spine looks like, and here is the MRI. So what it sounds like is she's been myelopathic for quite a while, and now she has central cord. So to work with that, ACDF of C4 to C7 was done, and that's looking good. But of course, her spine is still quite the specimen, and so she comes in throughout the process of recovering from that. So here is the history slide that I showed you before. We are now back to this, and what we see is that, well, first off, so sagittal alignment, she has pretty large SVA, but here we see that she has developed a pseudoarthrosis and stenosis that we can see at that T8-9 level, so easy to see on the CT. And so, now we're in the thoracic myelopathy, again, territory, and the plan is to correct that with a revision. Just revision arthrodesis, decompression.
So go back, Jared. So she actually, I don't know if you can see this, Jens, but she fractured, go back one more. So she fractured her rod right below the connector. Go back one more. So can you see that, Jens?
Yes, I can. And I've had the same case just last week. It's remarkable.
Is this was done MIS, the lower half. And for whatever reason, after her MIS, you can see she's really tilted off to one side. And I can't explain it, I think this has to do, you can see she kind of has a flat back, but ever since she had that MIS construct down at the level below, I can't explain it just based on the images because they don't look bad. Do you have any insight into why she would be leaning forward to one side? Because her hip doesn't look that bad.
Yeah, so this is a very complex issue. And again, there's a general, I call it Gestalt. So I use a good old German Yiddish word of Gestalt of the patient. I think that her GPS is depolarized. And usually people with myelopathy will lean forwards just for a seeking of balance. They look for a visual horizon. And so they kind of just can't look straight anymore. And it's asking a lot for people when we do a very long fusion to kind of stand straight. And we obviously hope for that, we look for that, we want that. But reality on the ground is frequently our patients lead their own lives. They want to bend forwards, and that's what we're predetermined with. Let me ask Pooja a question. So one of my pet peeves always was recognition of myelopathy. My thesis, my theory was that it's a completely under-recognized pathology, and that patients really go for a disturbingly long time in a developed country like ours with myelopathy. How do you feel we're doing in terms of myelopathy recognition now? Do you feel that this is a strong emphasis in training programs as you've seen it?
I do think it is, especially in my program. I know in clinic, we are always told in every exam, we always check for those myelopathy signs. And then when we're on call, we do have our attendings ask us if we notice those signs in certain patients. So I do think it is emphasized nowadays to us to make sure that we check in all our spine consults.
Because I was always disturbed how medical students had no clue about it. So I'm happy to hear that this is much better now. Sorry, there's a loudspeaker going off. So this is a ongoing crisis and battle. And again, it's a surreptitious silent form of spinal cord injury. And we really don't have, I think, a great latitude of recognition because it's not a simple exam. It's a complex thing. So it's not just something that you can see usually on an MRI scan. So Liz Walker, in your time doing a directorship with AO, I know that you've done some major programs in terms of myopathy and incomplete spinal cord injury care. Can you share a little bit about how this came about and how you were able to kind of push this to fruition and into fully fledged?
Yeah, thanks, Jen. So, you know, at AO, I also was at Medtronic as well prior to that. And, you know, this was certainly always an issue that that clinicians were struggling with. And so there were a number of different programs that were dedicated to this. I mean, it's just kind of an ongoing issue. I think that practitioners seem to have ongoing educational needs.
I really want to recognize you shepherding and making funds available for several of these programs. By the way, I wanted to point out we have many colleagues from around the world who've joined us here. So this is kind of a really cool group. Afghanistan, Greece, Turkey, I see here, and Latin America. So thank you all for joining us. So Rod, to your patient, I would do again, intradiscal osteotomy. It seems to work that well. Try to lordosa back as much as possible. The bigger question is, do you want to go to cervical 2 now to try to tilt her neck back more, or do you want to keep those 3 or 4 motion segments alive until they collapse?
Yeah, that's a good question. I haven't fully decided yet. I think we're going to get a CT and then see her in clinic and then make a decision. So.
But I would recommend fixing that non-union. I literally had the same patient, patient I did 8 years ago, and she's a drug abuser. I'm not blaming the patient, it is what it is, but she came with paraparesis, new onset, and lengthy, complex follow-up, and just a difficult time sorting out the various social circumstances. And finally, we got permission from her to do a myelogram after about a week, and we found a occult hardware fracture and an otherwise perfectly fused spine. So we just revised her. But these are very thankless cases. And again, with modern hardware, it's sometimes very difficult to pick up these non-unions. So I'm glad you found that out. And again, I'll be curious to see what you.
Yeah, great. Thanks, Sharon. So I think we're gonna now switch to. So I think Pooja has an excellent presentation. Pooja is a orthopedic resident at UW, and she's going to give her perspective. I think she's got a very nice talk on women in orthopedic surgery. So thanks so much, Pooja.
And I want to just point out, thank you, Rod. And thank you to our fellows for the cases, which show that this is a difficult field and a complex area. And again, we want to do a deep and very honest dive into why there's a gender imbalance. But in orthopedics and neurosurgery, we have a bigger problem at hand also. And spine is a subsection of that, which has a notoriously even worse problem. Dr. Prabhakar did a great job presenting at our Washington State Orthopedic Association. She's had well over 1,000 hits. And she also presented at our academy meeting on this due to her. And this is just a 5-minute kind of a brief perspective on her talk. So thanks, Pooja, for coming on again.
Yeah, thank you all. Thank you, Dr. Chapman. So like Dr. Chapman said, this is just a abbreviated version of a talk I gave last year. And this is about orthopedics in general, not specific to spine, but just kind of the barriers to diversity in our field and some things we can do to try to prevent that from continuing on. So I think at this point, I don't need to make a case that orthopedic surgery is not diverse. It's common knowledge now that even among people not in medicine, that most orthopedics groups look like this in this picture. So the current makeup of orthopedics in the US is nowhere close to being proportional to our country's population. Underrepresented racial minorities, or URM, make up about 32% of the US population, but only 9.8% of orthopedic residents, and only 3.6% of orthopedic surgeons. For women, we make up half the population, and we're only 16% of residents and only 6% of orthopedic surgeons. And here's a graph that shows how we compare to our fellow medical specialties in residency. So orthopedics, pretty close to the end at 10%. And then for gender, we're actually at the very end. So why is this a problem? First of all, patient outcomes are improved when care is provided by a more diverse team. This has been seen in many business studies, but also been proven in the medical field as well. Patients with race concordant doctors report that they are better able to participate in decision-making. Financial practice of the performance of the practice improves with increased diversity. Minority physicians currently provide more care to the underserved, which could potentially reduce disparities. Non-minority trainees report that racial diversity enhances their education. And overall, this enhances interest in the profession among underrepresented minorities and female students. So when we have increasing numbers of URM and women in medical schools, it is crucial that we remove any barriers that they have to enter orthopedics if we want to continue to attract the most qualified medical students. So what are the barriers? One, actually, lack of diversity in the field in itself is a barrier to having more diversity. You need to see people that look like you. Second is a lack of mentors and early exposure to orthopedics. There are also some socioeconomic barriers. There's, especially among female students, a perception that there's too much physical strength required, or a negative perception of the lifestyle, a job culture or stereotype, and hostile work environment. I wanted to bring up this Twitter and Instagram handle. It was fairly recently created account that aims to increase awareness of bias and harassment in orthopedic surgery. They share anonymous stories submitted by orthopedic surgeons, which I encourage you all to follow them and read some of these stories. And while these events make the work environment a hostile place, hopefully these kind of harassment type of events are becoming less common with time. But microaggressions occur many times throughout the day, every day. And microaggressions are brief, everyday exchanges that send denigrating messages to a marginalized group, and they stem from implicit bias. So there's a survey study that was published in JAOS that showed that over 92% of female orthopedic surgeons and residents reported experiencing microaggressions. So here's a few just examples of a few that myself and a few of my co-residents have experienced. So for example, assuming that some of us are nurses or janitors rather than a doctor, or not having our glove sizes stocked in the OR room. For medical students, sometimes when they're female students shadowing, it's just assumed that they're not there for orthopedics, they're there for another reason, or referring to, essentially in a clinic setting with patients, referring to the female doctors by their first name, but calling the male doctors with doctor. And then here's just a few examples of some statements during interviews that we've heard. For example, we only take female residents who played team sports. So one thing I wanted to know is how long will it actually take us to reach gender parity in our field? So there's actually a study that was published a couple years ago that looked at this, and they actually found that it would take 326 years for us to reach gender parity with the US population, which is 50.8% women, and that's at a constant growth rate of 2%. So what can we do to achieve a more balanced workforce in our field? There's multiple ways that we can do this in residency programs as well as in practices. So first, I think it's important to establish the achievement of diversity as a goal in your practice or in your residency program. Next, we need to take initiative to introduce our field to young people. That's even in private practices, we can reach out to youth groups, schools, host Sawbone workshops for them. Third is to join groups with a focus in exposing orthopedics to those who are underrepresented. So these are just a few organizations. I think the Perry Initiative and the Ruth Jackson Orthopedic Society specifically tend to target younger female students, especially in high school and college, so very early on. And then the J. Robert Gladden Orthopedic Society and Black Women Orthopedic Surgeons do the same for underrepresented minorities. And Dimensions also hosts a couple scholarships for first, second year medical students to go to other programs to get summer experiences with orthopedics. Next, I think we need to also be very proactive in mentorship and make sure that in addition to just introducing our field, we actually take certain students, either college students or medical students, under our wing and actually guide them and coach them. And lastly, I think we need to all increase our knowledge of microaggressions and implicit bias. Ways we can do this include asking people about their experiences, educating yourself and your colleagues through reading books, or such as even following some of the accounts that I mentioned. There's also podcasts such as the She Can Fix It podcast that is on Apple Podcasts as well, that interviews female orthopedic surgeons about their experiences. and calling out intolerant comments or jokes from colleagues or patients. And I'll just end with this concept of the ally continuum. So it shows how to progress from becoming an apathetic to an advocate for diversity. So I think we all know people who are apathetic about this topic and some who are aware but not active. So we all should aim to become active and then an advocate for diversity, which is committed and routinely proactively championing inclusion. So most of us are in this aware stage. We could take some steps that I mentioned to progress to the next stages. Thank you.
Pooja, that was terrific. I think, just speaking personally, as a neurosurgery resident, I can definitely empathize with, all those salient points that you brought up in your talk. And honestly, I think a lot of it has to do with the fact that there's just not enough, there's not enough diversity in those positions. And speaking personally, in neurosurgery, I was trained by all white males, right? There's not a lot of diversity in these subspecialties, and unfortunately, I think that detracts from the specialty. And personally, having 3 daughters, I'm super empathetic towards. I think a lot of the bias, it's not. It's just something that people it's just repeated over and over again, and it has to do, I think, with the fact that, again, our experiences are based on multiple things. But I think if you don't have mentors, you don't have diversity, I don't think things are going to change.
Yeah, totally, I agree. Especially like you're mentioning for spine surgery. I know in my experience, both as a medical student and as a resident, we don't have much diversity, at least in the programs that I've been to. So I think that is definitely a barrier, because we see, women or people of color in other specialties within orthopedics, but it is difficult, I think, in spine surgery to kind of see yourself in that when you don't have somebody that kind of looks like you to guide you.
Yeah. And
I was going to ask Jess,
yeah.
If she could talk about her experience in the job market as she was looking for jobs. Did she encounter bias? Was this an easy road to take?
Yeah, thanks, Dr. Chapman. So I'm almost 3 years into practice now, and I'll say, Pooja, excellent talk again. In terms of finding a job, I actually felt almost like the opposite. The groups that I was looking at were really interested in having a woman come on board. I think for exactly that reason, that it's getting talked about more, that we want to expand and increase our diversity, and people are starting in orthopedic surgery to really realize the importance of a diverse workforce. And so I was lucky in that aspect where it didn't really seem to be a gender issue. Even in residency interviews, overall was pretty, benign in terms of comments. I had one comment during a fellowship interview about why I didn't go into ophthalmology. But otherwise it's been, the recruitment process was a positive experience. Again, I think the day-to-day, like Pooja was talking about, is a little bit of a different story in terms of, again, I think it always comes back to, you have to be twice as good, twice as smart, twice as competent to get half the amount of respect. And I see that day-to-day with patients, some of my colleagues in my practice. I'm the first woman to join the practice. And so, I think there's been just an underlying current of implicit bias, which unfortunately is no one's fault. It's just kind of how our society is. And on a regular basis, a patient's asking me in the office if I'm going to be the one doing the surgery, commenting on my looks, commenting on my gender, commenting. And, I do exactly like Pooja mentioned, kind of redirect the conversation to talk about technical skills and education and training and background. And so, but it's something that our male colleagues don't experience. And, for them, I think it's been a big kind of light bulb going off. One of my mentors here, who just recently retired, recruited me, and he was a big advocate for women in ortho. And I think having more advocates like that, and he's the one that brought me into the practice. So, but having more advocates like that and not having to do it all on our own is the key to success for orthopedics, especially in expanding into fields like I do foot and ankle surgery, which I think has a kind of more of a higher number of women, along with sports medicine and pediatrics. But subspecialties like spine for sure, and joints, trauma is becoming more diverse, but kind of these specialties where there's not a lot of people that look like us, like Pooja so eloquently said, there's lots of room for change, and advocates like you, Dr. Chapman, who really make it a comfortable environment for a woman to feel like she can be successful.
Thank you for the credit.
Jens, I think they're going to close the door on you here very shortly, it looks like. It looks like you have a window seat.
I scored.
No aisle for you. Yeah, those are great comments, Jessica. And I think for us, we're part of SF Match. And we have 2 ortho fellows every year through the SF Match. We have 2 neurosurgery fellows, and we have 1 international fellow. And we also have a resident rotator. And, we have seen an increase in the number of applicants over the last 5 years. When we first started doing it, we didn't even have 1 applicant. And both Jens and I, were kind of shocked. But I think, historically, I do think programs are becoming more and more open and receptive. And I think, honestly, like for us, we really, we're dying to, participate. In fact, this year we have Amanda, we have a Johns Hopkins resident rotating with us. I'm seeing more and more women go into spine and neurosurgery, which is really exciting. And I think, there's a lot of positive things that have gone on. And I think, as you said, both Jessica, in the environment, I think you guys add speaking personally, it creates a different energy. And I think, we could all really benefit from having a more diverse workforce, just both in terms of gender, race, ethnicity, all those things.
I want to add to that. So all the presentations this morning came from white males, and I want to acknowledge that and recognize that, and that includes myself. So I think that's very telling. And as I'm introducing Liz Walker, I want to again reflect on Pooja's slide, which basically makes that leapfrog from awareness to activism. And being a active proponent who changes the field. So as we have gone through our interview processes, we found it very hard to actually match with female candidates. And I hold a sad record as having had 3 female fellows in my 30 years of having done academic spine education. So that's kind of a sad reflection. What I would like to learn and what I challenge all of us is to see what we can do better in terms of how we project ourselves. And I think Pooja's comments of mentorship, Jessica's reflections on the micro biases which inflect our thoughts and languages sometimes without our awareness, the implicit bias that is so important. So that's my personal learning goal from this lecture. And this is why I want to thank all 3 lecturers today in this mini panel for contributing to our education. Rod, should we go ahead with Dr. Walker?
Great. So our next speaker is Liz Walker. Liz is well known to most of us. She actually has been in the industry. She's been in sales. She's been in marketing. She's been in education. She did a lot of cool stuff and, worked with a lot of physicians. She worked at Medtronic. I think I remember her being at Medtronic. She helped develop their education, their global educational platform, and helped develop Catalyst, which is like Medtronic's physician education platform. And she also more recently led AO Spine and CMF and the North American division. And she did a lot of work in advancing surgeon professional activities, education, CME. More recently, she actually did a very interesting thing where she did her research and did a dissertation on women's advancement in the profession of spine surgery. And she did this at USC and recently earned her Doctor of Education in Organizational Change and Leadership at the Rossier School of Education at the University of Southern California. We're very lucky and privileged to have Liz. We've worked with Liz before, and this is an exciting talk. And I actually was very fortunate to read her dissertation. So I want to welcome Liz to our STED talk. Hi, Liz. How are you doing?
Hi, good morning. Thank you. Thank you for letting me join and share some information.
Great. We're excited to have you be on the other end. Normally, you're the one that's organizing everything, getting all the doctors to play ball together,
I know.
which is not always the easiest thing to do, right?
It's been a fun career for me. So and I've so enjoyed getting to know so many spine surgeons over the years, and just super excited to share the information that I've learned. Also wanted to commend Dr. Prabhakar and Corey. It's interesting to hear their comments that align with a lot of the findings in my study as well. So looking forward to sharing some information and hopefully starting a discussion.
Great.
Awesome. Okay. Let's see. All right, so just wanted to say I'm not an MD or DO. I'm not a doctor like that, but I did receive my doctorate recently, so I'm going to milk that for just a short period of time, as long as I can. As a part of my dissertation, I ended up studying women spine surgeons, what led to their retention and persistence in the field. When I was at Medtronic and also at AO at our resident training courses, there was a mix of women and men. And then as those courses progressed to fellowship courses or practicing surgeon, attending courses, the women just completely dropped off and really made me question, where are all the women? That kind of led to the research. The problem within spine is that women comprise about 5% of spine surgeons, and that's neuro and ortho. As you all know, currently there is a surgeon shortage that is expected to increase by 2033. There's supposed to be, or AAMC predicts about a $17,000 to $30,000 shortage of surgeons, not just spine, but surgeons in general, due to increasing aging population, increased access to care, also related to burnout and opting out of the profession altogether. And these projections were prior to COVID. So, those numbers are probably understated. From a patient access to care and a patient preference standpoint, about 18% of patients actually seek out and prefer women surgeons. And this is primarily due to the strong communication skills and empathy skills that women typically exhibit, which also leads to high loyalty rates of patients with their female or women clinicians. From an economic lens, Hunt et al., and this was through McKinsey, looking at organizations around the world, they demonstrated that gender diverse organizations were actually 25% more likely to outperform their competitors. And this was, across the board in the business segment, healthcare, every segment across the world. And so therefore, the lack of women in spine really impacts patient care, but it also impacts the bottom line. So again, my study is really looking at how women navigated the profession of spine from a persistence and retention standpoint. I had a qualitative study designed primarily because I wanted to interview and hear the voices of the women, from different age ranges, different races and ethnicities, to see if there were commonalities among these different groups. So the first finding that I came across is that gender bias led to constant behavioral adaptations and pivoting of the women. So since spine surgeons are primarily men, the women conformed to traditional societal gender norms of what we all view as what a spine surgeon looks like, how they behave, etc. So women working in male-dominated fields like spine surgery, they go against the typical stereotype of what we would view as a woman and a woman's profession, and that causes conflict. And actually, both women and men associate the profession of spine surgery and a spine surgeon as more of a man's profession. Some of the data and quotes that came up in the research, and I'm just going to point out a couple that are kind of interesting. So this first one, there's a personality and an attitude that you have to display that becomes more stereotypically male, like a way that you speak and your attitude to spar with everybody. And you tend to talk louder and have to be really pushy and really aggressive. So that was one of the women, her comments, and it was pretty consistent across the board. The other women said similar things. So the women spine surgeons became more loud and aggressive when they were working with other men, so generally men surgeons. And this person also said that she behaved in ways at work that outside of the OR would not be socially acceptable for women to behave. The other thing that kind of came out is that when these women surgeons were working with nurses who were generally women, some of them actually became more passive with this group of people. So this first quote, I'm expected to be less direct than men. If someone's not doing their job, which was talking about in the OR setting, I'm expected to deal with it a little bit differently. I can't just be like, you're not doing your job right. I have to constantly say, could you please do that? Could you please do this? Lots of pleases and thank yous. And when crap is hitting the fan, I have to spend a lot more energy going around the directness. So to kind of summarize this first finding, when women's spine surgeons were around men who were generally spine surgeons, they downplayed their gender, they assumed male mannerisms, and they became more loud and aggressive to get their points across. When they were around women, they were generally more polite and more passive. These behavioral adaptations were strategically chosen, and they were designed to elicit responses from their targeted individuals and groups. The different behaviors were employed depending on the expectation, the kind of gender expectation norms of the individual that the woman spine surgeon needed to influence at that particular time. Okay. Finding 2, and this speaks to, I think Dr. Coring was talking about, having to work harder and longer and so forth. This definitely was aligned with that. So women were held to higher standards and judged more harshly than the men. Since the number of women in the specialty is limited, the women were keenly aware of standing out and being easily recognizable. And so, they were not only singled out more often, they were judged more harshly than their peers, but they were also driven to be better than their men colleagues in order to stay above that line of approach. And they were held more accountable than the men were. So, that definitely came out in the research. Some of the quotes that came out, and again, 40% of the women revealed that specifically that they felt like they had to be better than the men. Women are held more accountable for their mistakes. For the minority, it's more obvious when you do something wrong. So just their physical appearance, looking differently, allowed them to be singled out more often. Another one, because I was female, I had to be just a little bit better, had to work harder, make sure I was always on top of my game. Minimize this. Most women try to be better to get the same recognition. We obsess over not making mistakes and building our reputation appropriately, especially at the beginning of their careers. The third finding is related to the gendered training environment that resulted because of the dominance of men that are in the field. And this really comes from, medical textbooks, clinical literature, are predominantly published by men over time. And so the overall learning environment proved to be gendered. It was presented from a male perspective and depicting the man as the real standard mental model of a spine surgeon. Also, we see this in medical industry that, works with surgeons to develop products, manufacture instrumentation. They rely primarily on men surgeons to design this instrumentation, to train colleagues on the instrumentation. Because women are generally smaller in stature than men, they have smaller hands. They are not generally as strong as women. What they ended up doing is they developed their own alternate surgical techniques. So the techniques that they were taught in residency, fellowship, et cetera, were not always accessible to them because of their size. So they ended up developing alternate techniques. And furthermore, this was kind of interesting, out of a desire for the women not to be seen as victims or to draw, additional attention to themselves, they would find these workarounds, these alternate techniques, but wouldn't speak up. And so most of the women told me the same thing, but they were not aware that other women were really having the same issue and had done the same thing. So a couple of the comments, the first one, women have to be technically proficient, more technically proficient, because we can't muscle things into place. We have to actually be really good at using the techniques to do what we need to do. In spine, you have to bend rods. So we become technically proficient, whereas sometimes the guys are just able to bend it. Okay. And the last one, people don't want women surgeons, and you must be good to be a woman in a man's world. The last finding was that this bias continues to accumulate over the course of women's careers, and unfortunately decreasing the possibility of advancement. And so, we've talked a bit about getting women into the field, which is definitely needed. But unfortunately, that's not the only problem. It's actually moving the women up into leadership positions. Previous research has been published that in male-dominated work settings, there's a homogeneity that leads to one leadership style, perpetuates those shared values that become socially ingrained over time and extremely difficult to change. And so these assumptions and unconscious or implicit biases of men, spine surgeons that are in positions of power, like faculty, publishers, researchers, medical device, designers, they lead to this projection of their own realities and worldviews on women's spine surgeons. And again, these assumptions are demonstrated in textbooks, curriculum, teaching of techniques, et cetera, where the man is assumed the mental model or standard. So 90% of the women experienced implicit bias, unconscious bias. And I think Dr. Prabhakar mentioned that as well in her research on a regular basis. And this comes from everybody. It's not just men. It comes from other surgeons that are both men and women. It comes from residents. It comes from nurses who are generally women. It comes from patients who are men and women. Sales representatives who are generally men, and attendings, so it really comes from everywhere. It's widespread, these experiences. And it really demonstrates the powerful influence that stereotypes play in our society. And they continue to reinforce this myth that women don't belong in spine surgery. One of the interesting quotes here was from a program director, and she said it was interesting and disappointing, and this was within the last year or so, that even the residents' expectations on their surveys, the program director surveys, were gendered. They said that she wasn't maternal enough, that she wasn't feminine enough, that she was too mean, and that came out in the resident surveys. So, we were talking about stereotypes and that contributing to the lack of advancement. There is some work that's been done over the years. Ibarra and Petroglieri talk about impossible selves and this concept. Okay, I'm just going to continue talking. I think somebody may need to mute.
Sorry about that.
Okay. Thank you. Anyway, impossible selves is really illustrating the complexity that cultural factors and stereotypes play on women's leadership journey. And Eagly as well has done a lot of work in this space, talks about the leadership labyrinth of women, and how it's really a complex labyrinth of continuous barriers to get to that leadership level. So I'm not sure exactly where we are on time. I certainly have some recommendations, but we could take a few minutes if people have any questions. And then if we want to talk about recommendations, I can certainly talk about that as well.
Liz, we're good. Keep going.
Okay.
Yeah.
Okay, awesome. So one of the first recommendations is, within the departments of spine surgery, and I'm kind of lumping in orthopedic and neurosurgery as well, really establishing a diversity and inclusion task force. These task forces have been successful in changing cultural dynamics. There's certainly no one-size-fits-all approach to increasing representation, and solutions really need to be customized to, the environment that you are desiring change in. However, in spine surgery specifically, special attention needs to be paid in decreasing gender bias, especially during interviewing and recruiting practices. It was very nice to hear that Dr. Coring's recent experience has been, a very positive one. Providing assessment and feedback similarly to men and women. And so a lot of the women that I interviewed talked about they weren't really getting the feedback that they thought that they needed in order to get better, especially during residency. And they felt like the men were getting better feedback. So they want that feedback on how they can do better and, clinically be better, and hope that their attendings, won't be nervous about providing that feedback. So they definitely want that feedback. Leadership succession planning. So, this really needs to be taken into consideration with an eye toward hiring and promoting qualified women. There are certainly, plenty of qualified and great women leaders out there. And, we know from the research now that they've really crossed many barriers to get where they are. And so that succession planning needs to be considered. Creating a safety culture, and specifically regarding attending surgeons, literature talks in the business world quite a bit about the role of managers, as opposed to like the CEO of a company. But those managers really play the most important role in an organization's success and with staff. And attending surgeons can really play that role within medicine, and they have that power to make impactful changes. Visual symbols, that's really important. And as crazy as it sounds, it is important to have visual symbols of women in leadership, even if that's not representative of the population, because women need to see other women in order to think, hey, I can do that. So visual symbols are important. And then engagement and inclusion efforts and are super important. You're not going to really get diversity and success without inclusion. So the second recommendation is for organizations to provide opportunities for people, employees, and staff to increase their knowledge about gender literacy, about implicit bias, and really through engagement, conversation, education, and inclusion. We know that mandatory education is not successful, and probably many of you all can relate to, the myriad of compliance trainings that you have to do for your organization, or all these online trainings that you have to do, but they're actually more effective on gender literacy, making it available, and having some efforts around engagement, and just to really have some conversations about people's experiences, looking to the literature, reading some books or articles, and having some real in-depth conversations. There are also some other resources that could be helpful, and I'm happy to provide some of that information if anybody is interested. I will, provide any of that information as well that can help you kind of get started in having those conversations. So mentoring and sponsorship, and this was brought up earlier, this is really key. And in the literature, there is a designation, kind of a difference between mentoring and sponsorship. Mentoring typically meaning, providing information to another person, kind of guiding them along. Sponsorship is a concept where the person that has influence and power is sponsoring a person and trying to help them move up the chain. And so sponsorship is critically important to helping women move up, and introducing to them to other influential others, helping them get involved in certain important activities like research and things like that. So the sponsorship piece is really important. The third recommendation is really about residency and fellowship training programs, as well as for medical manufacturers. And these groups should work to incorporate inclusive teaching and product design practices. And, related to teaching, this can, I would say, take the form of allowing women to teach these alternate techniques, these tips and tricks that they're using in spine to make things work. It's also really important that women shadow other women, even if they're not in the same training programs. Even in spine, if there's not somebody, within spine, it would be helpful, for them to shadow other women in either orthopedics or neurosurgery, just because that shadowing, the working with patients is so different, or is what I've learned from men and women, that was something that really came out of the research. And then finally, medical manufacturers to use more inclusive design practices, to make sure that they have diverse groups of teams, whether they're advisory boards, focus groups, developing new products, so that all the voices are heard and that they can accommodate different types of practitioners. Final recommendation has to do with professional societies. And, professional societies have a real important, tremendous power actually in making some change in the profession. Utilizing unbiased criteria to select members for their committees, for research, for podium presentations. They can also provide mentoring and sponsorship programs where women can network with other influential people, develop any leadership skills that might be necessary. It also helps their CVs and advancement opportunities. So professional societies definitely have a huge role here. And that's kind of it from my standpoint. Again, feel free to reach out. My email is on the screen. I'm happy to have a conversation or share any other information that I can share, and I'm happy to answer any questions or join the conversation.
So Liz, that was terrific. I have a couple questions. The first one is on diversity. I have a unique perspective, but I think, when you look, for example, and if you look at neurosurgery, I'll give you a neurosurgery example. Why is it that we have no Black neurosurgeons, and that continues to be a problem, but also on the gender side? Do you think, is it something that we can really change when I think that, like you just pointed out, you have these criteria, and in addition to that, for example, I'll give you one thing, like standardized tests, right? So do you think it's a fair system that we have set up, or do you think, is it kind of flawed from the get-go?
So thanks for the question. When you said a flawed system, I'm sorry, what were you talking about specifically?
So I'm just using neurosurgery as an example.
Mhm.
Okay. So when I look at my peers, and I think actually Pooja showed an excellent slide there where it's all white males, right? And that was an orthopedic thing, but you can apply that to neurosurgery, okay? And my question to you is that, do you think our selection process is flawed? And I'll give you one example. So in order to get into neurosurgery, you have to do very well on standardized tests, okay? There's a lot of institutional bias in these tests, and do you think that our system is flawed? And do you think it's biased towards certain, racial groups and gender, across the board? Do you think they're fair?
I'd love to hear Dr. Prabhakar's answer as well. I mean, I think it has been established, I know, and, just related to standardized tests, whether it's ACT or, things like that, that these tests are definitely flawed from the sense of, looking at different races and ethnic groups and judging everybody by that same standardization. And so I think, in medicine, that's certainly something to look at that criteria, but that has been established in other measures, and it may have as well in medicine. I'm not sure.
Yeah, I can comment a little bit on that. I do know, and I had actually put a slide about this in my previous talk. I took it out for this talk, but for at least gender, the selection for women in orthopedics, and probably the same in neurosurgery, it actually is the same in terms of like the percentage of women that apply to orthopedic surgery and the percentage that get selected in. It doesn't seem to me like that is a problem among like gender, but for race, there is kind of a lower percentage of people in underrepresented minorities that get selected compared to the percentage of applications. And I do think definitely what you said about, it's kind of institutionalized, the bias with the standardized testing, but even it's been shown like AOA standing, like that's definitely kind of a biased system. And so when we use those markers of things that we use to select people in, even for just interviews, I think that can definitely put some people at a disadvantage. So I think kind of choosing what we look at for interviews, especially among underrepresented minorities, hopefully that could change.
There's actually some work that you all may be familiar with, but it was, this was years ago, and I'll try to find a study or where it was published initially, but it had to do with orchestras. And at some point in the past, in order to try to decrease some of the bias that in their selection process, they started judging musicians behind, a curtain. So they couldn't see what they looked like. They were just literally listening to the music that they were playing. And in that realm, it actually really helped them to these orchestras to get the best group of people that they needed for, those certain orchestras. So I'm certainly don't know that would necessarily work in medicine or some other fields, but it's one approach that was taken in another setting.
And then how about Pooja? What are your thoughts on, I mean, you just named one of them, but I think, when you look at orthopedic, when you applied for orthopedics residency, I mean, didn't you basically have to get, really high scores in all these standardized tests and be a member of AOA and you have to kind of check all these boxes, right?
Right, yeah. And that is, the same for everyone, like male, female, everyone. But I do think, maybe, at least in my experience that I've seen, even like within my female co-residents, we definitely have a bit higher standard that we have to reach. And even this year I did residency interviews. I definitely saw like among the female applicants, there was just like everyone, again, all across the board, everyone was stellar, but I found the female residents or applicants had to do a little bit more across the board.
And then how about in terms of, so when you're in medical school, what was the mentoring process? Like, how did you end up deciding to go into orthopedics? Because I think that's one huge thing that Liz, you pointed out, I don't think there's enough mentors, but how did you get inspired to go into orthopedic surgery?
Yeah, I actually, even before med school, knew I wanted to do orthopedics, but that's because I had a mentor during a summer research program right after high school. It was at MD Anderson. And the mentor I had, she was a Black female surgeon who was the chief of the department. So I had, someone who I was working with every day for the summer who looked like me. And so it wasn't a weird thing for me to think that I could also go into that field. But I think if I hadn't met her or I had not had that experience, it probably would not, or orthopedics would not be something that I would kind of easily think that I could do if I had just, gone to medical school and seen the like current makeup of the orthopedic department there.
And how about now? Like, are you thinking about doing a fellowship? Like, what's your
I'm
career
getting a fellowship. I think right now I'm between foot and ankle and shoulder elbow.
Okay. And then how much of a factor how much do you think did you have during residency? Did you have exposure? Was there, how did you decide to go into that subspecialty?
That was partially from my sub-I experience and then also from my rotations at UW. So I think, it's mainly rotation based, and actually there aren't any female surgeons in those specialties either, at least at my program. But so that was kind of more based on the actual field itself. But I definitely think it would have helped to have more in kind of like all the specialties, but just happened at our program, we don't.
And how many other women are there in the residency program?
So we have 40 residents, and I think we have about 9 or 10 women in our program, which is quite high. That's not normal.
Yeah, that's a really good number. And do you feel like things are getting better, like since you started residency?
Yeah, I think at least in terms of, I think I've noticed more women getting into orthopedics or into residency just from like anecdotal evidence. Like Liz was saying in her talk, like it is, one thing to like get more people into the field, but it's another thing to actually like, once they get into the field, like help them and like support them. And I think that's true even for when selecting residency programs. Like you can look at the kind of roster and see like, okay, this program has more women or has more people of color, but that actually doesn't mean that they are a supportive program. Like they, might not have faculty who are supportive of like either just like mentoring or coaching or kind of just like championing diversity, like I mentioned. So, even there might be programs who are mostly all white male, but they might have a better kind of view on kind of championing diversity, kind of not. So I don't want people to think that just because, a program or a place doesn't have diversity, that they wouldn't be a good place to work or do residency. Kind of just depends on people's mindset at those places.
And then Liz, just to close out, thank you so much, Pooja, is, I do think the societies have a huge role, and so does industry. And, even the AO or, some of the other AOA or double AOS, double ANS, CNS. I think, I don't know what your thoughts are, but I think, historically those have been dominated by, certain groups. And I think you pointed out in your, great talk, I do think they also play a role. How do you see that changing? Because, obviously that's an important part of the evolution of, I think, what happened.
Yeah, I think, professional societies definitely have a lot of power. And Dr. Prabhakar did talk about this or showed some of those organizations that are making some strides specifically for women. I do think it needs to be more mainstream, commonplace. There are women in the specialty. It just needs to be normalized, and they're good clinicians just as men are. And so I think it needs to be intentional. So certain things that societies can do, they can, when they're selecting committee members, whether it's for research or education committees or so forth, they can set some criteria on the front end. Hey, we want people to have this type of experience to be on the committee. And then look at the membership list and try to match some of that together. That's not always going to work, but the more, objective that you can be with selecting people, I think it's just somewhat leveling the playing field. I think, what I've seen in the past is, let's say we need a new member on the education committee. We'll get a group of people together and like, oh, let's see if so-and-so is available or so-and-so is available. And there's certainly great, people to be on the committee, but the women aren't even thought of. They're not even a part of the conversation. And I think just trying to raise awareness that, oh yeah, there are these great women out there, that are wonderful clinicians, researchers, et cetera. Let's make sure that they get discussed as well and can be a part of the conversation. Also, the men leaders in the field have so much power in being able to help others. I talked a minute ago about sponsorship. And again, sponsorship is really kind of taking somebody under your wing and introducing them to people, a younger person that you see that untapped potential, and giving them visibility to your influence, your power base, getting them involved in some of the research that you may be doing or other areas that can put them in a place of influence as well.
Great. Well, thanks so much, Liz and Jess and Pooja. Really appreciate everybody's input and great insights.